Good morning. In this lecture, we will talk about the surgical aspect of the adrenal glands and parathyroid gland. To start with, just a few points about the anatomy of the adrenal gland. As you know, we have two adrenal glands, the right one and the left one, located on the superior wall of the kidney. The most important points in the surgical anatomy of the adrenal gland is the blood supply of the adrenal gland. And most important is the venous drainage of the adrenal gland. On the right side, we have the main adrenal vein that drain to the inferior vena cava, and on the left side, the main adrenal vein drain directly to the left renal vein. We have three arteries to supply the glands on the left and on the right side. The superior adrenal arteries originate from the inferior phrenic artery, and the middle adrenal arise from the aorta, and the inferior adrenal artery arise from the renal artery. The normal adrenal gland weight about 4 grams, and it composed from the inner adrenal medulla and the outer adrenal cortex. As we said, it is situated on near the upper pole of the kidney, and the retroperitoneum included in the Gerota fascia. Now, the first condition related to the adrenal gland is we call it incidentaloma. The definition of incidentaloma is an adrenal mass detected incidentally by imaging studies conducted for other reasons, not known previously to have been present or causing symptoms. The meaning of this definition, you discover the adrenal mass incidentally during investigation for a complaint or a symptom not related to the adrenal gland, and there is no presence of the adrenal mass previously. So this is, we call it an incidentaloma. The incidence of incidentaloma is about 1% in the imaging studies, and 75% of these incidentaloma are a non-functioning adenoma, but it might be a Cushing adenoma secreting cortisol, or pheochromocytoma, or it is a secondary metastasis, or it might be a primary adrenal cortical carcinoma, and Cohn's tumor can all be found and discovered as incidentaloma. Regarding the diagnosis, once you discover the presence of incidentaloma, you should take a full history and physical examination to the patient, and then you have to exclude whether this incidentaloma is functioning or not, and whether it is a benign or malignant tumor or mass. So we will start by doing a hormonal study for the function of the adrenal gland, and this includes a morning and midnight plasma cortisol level, and 1 milligram overnight dexamethasone suppressant test, and 24-hour urinary cortisol excretion. And the measurement of 12 or 24 hours urinary excretion of metanephrine or plasma-free metanephrine. This indicates the presence of pheochromocytoma. Also, measurement of serum potassium, plasma aldosterone, and plasma renin activity. And Also, the measurement of the serum dehydroepiandrosterone and testosterone or 17-hydroxyestradiol, and this indicates the presence of virilizing or feminizing tumor. The next investigation is the radiology. All patients with adrenal mass as discovered as incidentaloma should underwent a computed tomography, CT scan, or a magnetic resonance imaging MRI. What is important by the imaging study is the size of the tumor. About 25% of the incidentaloma will be an adrenocortical carcinoma when the size of the tumor is more than 4 centimeters. So there is a direct correlation between the size and the incidence of the malignancy in the adrenal and if the patient give a history of primary cancer elsewhere in the body, so the adrenal metastasis will be more likely, and here the patient will need a biopsy from the adrenal gland to confirm the presence of metastasis to the adrenal gland from the primary tumor elsewhere in the body. But before you doing the adrenal gland biopsy, you should exclude the presence of pheochromocytoma by biochemical investigation, because if you do a biopsy and patient is having a pheochromocytoma, there will be an exacerbation of the pheochromocytoma, and this will be dangerous for the patient. So the indication for adrenal gland biopsy is to confirm the adrenal gland metastasis. Regarding the treatment of incidentaloma, it depends on the tumor size and whether the mass or the tumor is functioning or not. So in general, if the mass is more than 4 centimeters, this will be an indication for surgery. If the mass is functioning, also this will be an indication for surgery regardless the size of the tumor. But if the mass is less than 4 centimeters and it is non-functioning, so the treatment will be by follow-up of the patient after 6 months, and then after 1 year and 2 years by imaging, MRI, and hormonal evaluation. If the tumor kept in the same size and it is not functioning, so there will be no need for surgery. If the tumor get increased in size or functionally become active, so it will need a surgery on the next session. Regarding the adrenal metastasis, about 1/3 of patients having a malignancy in the adrenal gland, 1/3 of them there will be an secondary metastasis from a primary elsewhere in the body. And the most common primary tumors are the breast, lung, renal, gastric, pancreatic, ovarian, and colorectal cancer. In selected circumstances, an adrenectomy is appropriate. For example, if it is the sole site of metastasis, metastatic disease, this is, we call it a metastectomy. So if the patient having a metastasis to the adrenal gland and having a primary tumor elsewhere, for example in the breast, and this metastasis is the only metastasis in the body, and the primary tumor in the breast is under control, so here there will be an indication to excise the metastasis in the adrenal gland, and this is, we call it a metastectomy. Next topic would be adrenocortical carcinoma, primary carcinoma of the adrenal gland. Regarding the pathology, the pathological differentiation between the benign and malignant adrenal tumors is sometimes challenging. So we depend on the tumor size. As the tumor size increasing, so the chance of malignancy will be more. The presence of necrosis or hemorrhage, this might increase the suspicion of the malignancy. And regarding the microscopic features such as capsular or vascular invasion, This will be an indication for the presence of the malignancy. And the macroscopic features are commonly multinodularity and heterogeneous structures with hemorrhage and necrosis. This might indicate the presence of malignancy. And those patients with non-functioning tumor usually present with the complaint of abdominal discomfort or back pain caused by large tumors. Adrenal tumors secreting more than one hormone in excess or feminizing or muscularizing steroids are likely to be malignant. Regarding the diagnosis, as we said, we will start by the measurement of the hormonal levels to know that whether it is functioning or not. The radiological investigation, the MRI and CT scan are equally effective in imaging the adrenocortical carcinoma. MRI angiography is useful to exclude tumor thrombus in the vena cava, and CT scan of the lung also it is recommended. Regarding the staging of the adrenocortical carcinoma, we have what we call it a McFarlane classification, and we have 4 stages depending on the size of the tumor. Tumor less than 5 centimeter, it is a stage 1. More than 5 centimeter, it is stage 2. Locally invasive tumors, stage 3. A tumor with distant metastasis is stage 4. Adrenocortical carcinoma, which is functioning, tend to be more malignant than the non-functioning, and the prognosis will be worse. But these functioning tumors will have the advantage of serum marker, which can be used for follow-up and disease monitoring. After surgery, the patient can be treated with chemotherapy like the mitotan alone or in combination with etoposide, doxorubicin, and cisplatin. Adjuvant therapy may reduce the rate of the local recurrence, and restaging every 3 months is required as the risk of a tumor relapse is high. Regarding the prognosis of the adrenocortical carcinoma, for stage 1 and 2, the 5-year survival will be 25%, and stage 3 and 4, the 5-year survivors will be 6 to 0% respectively. The next condition in the adrenal gland is the pheochromocytoma and paraganglioma. The definition of pheochromocytoma is the tumors of the adrenal medulla and sympathetic ganglia, which are derived from chromaffin cells and produce catecholamines. Regarding the etiology, we have an sporadic pheochromocytoma occurs around the 4th decade, and we have a hereditary pheochromocytoma which is diagnosed earlier. The pheochromocytoma is a 10% tumor. There will be a 10% of the tumor inherited, and 10% of the tumor are extra-adrenal, 10% are malignant, and 10% are bilateral, and 10% occur in children. Regarding the hereditary pheochromocytoma, it occurs in as a part of tumor syndromes, and the best example is the multiple endocrine neoplasia type 2. Regarding the pathology of the pheochromocytoma, grossly the tumor will be grayish pink on the cast surface and are usually highly vascularized, and there will be an areas of hemorrhage or necrosis observed in the tumor. This is the picture of pheochromocytoma, in the adrenal gland, gross appearance. And also the same in the adrenocortical carcinoma. The differentiation between the malignant and the benign tumors is difficult, except if metastases are present. If you have a pheochromocytoma in the adrenal gland, you cannot differentiate pathologically by the whether it is a benign or malignant unless there is a distant metastasis. If there is a distant metastasis, that this means that the this pheochromocytoma is a malignant. Regarding the clinical feature, there will be a symptoms related to the secretion of the catecholamines, which occurs typically in an intermittent way. And there, in 90% of the patient, there will be a combination of headache, palpitation, sweating, and there will be a paroxysms of these symptoms precipitated by the physical training, induction of the general anesthesia, and numerous drugs and agents like the contrast media, tricyclic antidepressive drug, and metoclopramide and opiates. Hypertension may occur continuously or intermittent, or sometimes it is absent. Some patients with pheochromocytoma are sometimes asymptomatic. Regarding the diagnosis will be by the measurement of the adrenaline and noradrenaline breakdown products, which is called metanephrine and normetanephrine levels in a 12 or 24-hour urine collection. Also, determination of the plasma-free metanephrine and normetanephrine levels. Also, it will be high, of high sensitivity, and biochemical tests should be performed at least twice. So, localization of the pheochromocytoma by using an MRI is preferred because the contrast media used for CT scan can provoke paroxysm of secretion of the adrenaline. And classically on MRI, the pheochromocytoma will show a Swiss cheese configuration, like in this picture. Also, we have what we call a single photon emission computed tomography SPECT. This will identify about 90% of primary tumors and is essential for the detection of multiple extraadrenal tumors and metastases. PET scanning. PET scanning using FDG PET or DOPA PET is more sensitive in detecting metastatic foci. Regarding the treatment, the gold standard treatment is the laparoscopic resection, and now it is a routine in the treatment of pheochromocytoma. If the tumor is larger than 8 to 10 centimeter or radiological signs of malignancy are detected, open approach should be considered. Once pheochromocytoma has been diagnosed, an alpha adrenal receptor blockers like phenoxybenzamine is used to block catecholamine access and its consequences during surgery. With this preoperative medical treatment, the perioperative mortality rate has decreased from 20 to 45% to less than 3% after this preoperative medical preparation and treatment. We will start by a dose of 20 milligram of phenoxybenzamine initially, increased daily by 10 milligram until a daily dose of 100 to 160 milligram is achieved, and the patient reports symptomatic postural hypotension. Beta blockers is required if tachycardia or arrhythmia develop, and this should not be introduced until the patient is alpha During the surgery for the pheochromocytoma, there should be a special attention to the adrenal vein when it is ligated, as a sudden drop in the blood pressure may occur. So to prevent that, there should be an infusion of large volumes of fluid or administration of noradrenaline. This will be necessary to correct post-operative hypotension in the presence of unopposed alpha blockade. Regarding the post-operative follow-up, the patient should be observed for 24 hours in the intensive care or high dependency unit, as hypovolemia and hypoglycemia may occur. And there should be a lifelong yearly biochemical test performed to identify recurrent metastatic or metachronous pheochromocytoma. As we said, since its introduction in 1990, laparoscopic or retroperitoneoscopic adrenalectomy has become the gold standard in the resection of the adrenal tumors, except for tumors with a sign of malignancy. An open approach should be considered if radiological signs of malignancy, distant metastasis, large tumor more than 10 centimeter, or distinct hormonal pattern suggest malignancy. This was the most important aspect, surgical aspect of the adrenal gland. The next will be the parathyroid gland. The most important aspect, surgical aspects regarding this gland will be discussed in the next slides. Regarding the function of the parathyroid hormone, it activates the osteoclast to resorb bone and increase calcium reabsorption from urine, and renal activation of vitamin D with subsequent increased gut absorption of calcium, and renal excretion of the phosphate is also increased. The first primary hyperparathyroidism, the first condition in the parathyroid gland is the primary hyperparathyroidism. Usually it is a sporadic rather than familial condition, and it is associated with hypercalcemia and inappropriate increase in the serum parathyroid hormone levels due to enlargement of one or more than one glands and a hypersecretion of parathyroid hormone. Like the pheochromocytoma, familial hyperparathyroidism can occur as a part of the following genetically determined condition, and the first one is the multiple endocrine neoplasia type 1, and we have a multiple endocrine neoplasia type 2A, and rarely in multiple endocrine type 2B. Regarding the pathology of the primary hyperparathyroidism, as we said, the majority, about 85% of patients with sporadic primary hyperparathyroidism have a single adenoma, and about 13% have a hyperplasia affecting all four glands, and about 1% will have more than one adenoma or carcinoma. In familial disease, multiple gland enlargement is usual. Regarding the clinical presentation of hyperparathyroidism and hypercalcemia, there will be a renal stone, and there will be an affection to the bone. There will be a severe bone disease, we call it von Recklinghausen disease. There will be renal calculi and calcinosis, as we said. Hypercalcemia will precipitate the pancreatitis, and then there will be a psychiatric disorder. This is the cardinal symptoms of the hyperparathyroidism and hypercalcemia and full-blown features, but sometimes you can diagnose the hypercalcemia or hyperparathyroidism by the assessment of the serum level of parathyroid hormone and calcium before the patient reaching to these characteristic or classic symptom. Regarding the diagnosis, the biochemical measurement of the total serum calcium and parathyroid hormone and phosphate will indicate the presence of primary hyperparathyroidism. In this condition, there will be an elevated serum calcium and decrease in the serum level of the phosphate, hypophosphatemia, and the parathyroid hormone will be either elevated or normal. This will indicate the presence of primary hyperparathyroidism. Regarding the treatment of the primary hyperthyroidism, the surgery is the only curative option, and it should be offered to all patients with significant hypercalcemia, provided they are fit for this procedure. We have some medical strategies and therapies, particularly in mild hyperparathyroidism, which includes simple expectant treatment until the calcium level or symptoms reach a level at which surgery becomes more attractive. And these measures are a low calcium diet, withdrawal of drugs like diuretics and lithium, which aggravate the hypercalcemia, and we may use a calcium reducing agent such as biphosphonate and the calcium receptor agonist calcate. Occasionally, patients may present with a parathyroid crisis and severe hypercalcemia, and the serum calcium level will be greater than 12 milligram per deciliter. This will result in confusion, nausea, abdominal pain, cardiac arrhythmia, and hypotension with acute renal failure. Treatment for this crisis will start by intravenous saline and bisphosphonate therapy required to correct the dehydration and hypercalcemia. And this patient should be treated in high dependency unit or even intensive therapy unit to monitor the major physiological fluxes which result. The indications for surgery in primary hyperparathyroidism, indication for parathyroidectomy when the patient having urinary tract calculi or reduced bone density or high serum calcium, and also in a young patient, young age group less than 50 years, when there is deterioration in the renal function or the patient have a symptomatic hypercalcemia. Very important before the surgery, you should localize the hyper-functioning parathyroid gland. As we said, we have 4 parathyroid gland. It might be single one adenoma, or it might be all 4 glands hyperplasia, or it might be multiple adenomas or carcinoma. So the preoperative localization is very important by using a high frequency neck ultrasound. And also we have a technetium 99 labeled system EB isotope scan. This will identify 75% of abnormal parathyroid gland. The area scanned must include the mediastinum to detect the ectopic gland. This is the picture of system EB scan showing an adenoma in the right lower parathyroid gland. This is a system EB isotope scan. We can use a SPECT scan that give a 3D dimensional three-dimensional image which may influence the surgical approach. This is the picture of the SPECT scan giving a 3D image of the parathyroid adenoma. Regarding the surgical treatment of primary hyperthyroidism, hyperparathyroidism, we have first approach by targeted small incision approach, and we might use a conventional thyroidectomy incision. This is most frequently performed to do a bilateral exploration of the parathyroid gland. Also, we can use a minimal invasive technique like the video assisted or totally endoscopic technique with multiple punctures to do a parathyroidectomy. For the perioperative localization of the parathyroid gland, we can use a gamma probe. This used to guide the exploration following preoperative injection of technetium labeled cystamebi. Because of the short serum half-life of parathyroid hormones, we can measure the parathyroid hormone levels intraoperatively, and this can be used to confirm that the source of the excess parathyroid hormone production has been excised. So the level of the parathyroid hormone are measured before the incision and before the removal, and 5 minutes after removal and 10 minutes after removal. The assay will take about 30 minutes, and if the percentage of a drop is not more than 50%, then further exploration is indicated, because this means that there is still an over-secreting parathyroid glands not excised. So this needs further exploration. The principle of the surgery: the all abnormal glands are excised, and in the event of sporadic four glands disease, subtotal parathyroidectomy is carried out, preserving approximately 50 milligram of one gland. And this half of the one gland should be marked with non-absorbable suture to facilitate any possible future re-exploration if there is a recurrence of hyperparathyroidism. Regarding the parathyroid carcinoma, as we said, it is a rare, and it consists about 1% of the cases of primary hyperparathyroidism. The typical features will be very high serum calcium and parathyroid hormone levels, with palpable neck swelling and occasionally some lymphadenopathy. The scanning may support the diagnosis of the carcinoma. Regarding the surgical treatment, this should include the excision of the tumor mass with in-block thyroid lobectomy and not dissection when it is indicated.